It is my great pleasure to introduce the inaugural Gastro Journal Club. This is a feature developed by myself and David Weinberg as Editors-in-Chief of Gastroenterology. And our hope is that we will discuss key papers in gastroenterology using a journal club format. So this is really by residents for residents, and this will be a format where the author presents their work and answers questions that the residents are interested in about the paper, very much like a journal club that you all have for your academic half days. This will start at McMaster University, but over time, hopefully other universities, if they're interested, can take part and have their journal club at their institution. And as I say, this will start at McMaster University, and these are our fantastic residents, led by Chief Residents Julie Tan and Dennis Wang. And after this session, then after I've spoken and Lauren Lane has presented, Dennis will take over chairing this group. So it is my great pleasure for this inaugural journal club to introduce Professor Lauren Lane, who has an amazing CV. He qualified from UCLA in 1979. Did his residency in UCSD before taking a faculty position in the University of Southern California. He was born and raised in Los Angeles, so I think all his colleagues thought that was where he was going to stay, and indeed he did stay there for 27 years. You know, his research career flourished in San Diego, where he got hold of a Yale database on GI bleeding. And from there, he was sold on clinical research, produced an incredible body of work, first around GI bleeding, but then on NSAIDs and H. pylori and ulcers in general. He met a young person called Deborah Cook in Stanford, where he learned from her systematic reviews. Deb Cook, our residents will know, is a McMaster University, a proponent of evidence-based medicine. So there is that McMaster connection there with Lauren. And the other connection is I first debated against Lauren Lane on a systematic review on H. pylori in Hawaii, which he won, of course, but it was there that I was invited to look at a job at McMaster University. So the main reason I'm here is because of Dr. Lane, you guys. It's his fault. So he's got a lot to answer for there. But anyway, he then moved to Yale, which I think surprised lots of people, to become director of clinical research there. Although, if you think about it, his parents actually came from the East Coast, as his wife was from the East Coast as well. And so it wasn't as a strange a choice as that. And in fact, Yale is an amazing university, which he is now growing as chief of digestive diseases there. So, as I say, he has an incredible body of research, published over 450 papers, cited over 33,000 times, and as I say, an amazing body of work in New England Journal of Medicine, JAMA, Annals of Internal Medicine, and of course Gastroenterology. And it is the latest paper from Gastroenterology on vonoprazan in reflux disease that Lauren Lane is now going to present. So, Professor Lane, over to you.
Well, thank you so much for the invitation. It's really an honor to be asked to do the inaugural Gastroenterology Journal Club, and it's great to see Paul, and as Paul said, I also have some connections McMaster as well in the past. So this is the paper that I'm going to be discussing, one that appeared in the January edition of Gastroenterology. And by way of introduction, Proton pump inhibitors, or PPIs, of course, everybody knows, have been a mainstay of treatment for erosive esophagitis for years. And recent guidelines suggest they should be used for healing of erosive esophagitis and for maintenance of healing for more severe LA grade CD. But PPIs aren't successful in all patients with erosive esophagitis. There is a lack of healing and recurrence in a minority of patients, and this is more common in people with more severe erosive esophagitis. So as many of you may know, there's a new category of anti-acid medications, potassium competitive acid blockers, or PCABs, and they do provide somewhat more potent inhibition of gastric acid than PPIs. And we also know from old work that healing of erosive esophagitis is related to the degree and duration of gastric acid inhibition as well, with the McMaster tie-in is there as well, Paul. So it would make sense to consider that they might heal erosive esophagitis to a greater degree. But 3 double-blind randomized trials from Asia looking at healing at 8 weeks all found that the PCABs only had about a 1 to 3.5% higher healing rate than did the PPI lansoprazole. But we also know that Asian and Western populations differ in a number of factors that may influence acid inhibition. For that reason, we performed a double-blind randomized trial that compared vonoprazan to the approved doses of the PPI lansoprazole for healing and maintenance of healing in a US and European population of patients with erosive esophagitis. So let's get to the methods. To be included, you were an adult with erosive esophagitis documented at endoscopy. And I think an important component of our study was the fact that study eligibility and also the subsequent outcomes were based on blinded review of endoscopic photographs by experts, Ken DeVault, Phil Katz, and Stuart Speckler, rather than just the local investigator making that determination. Now, obviously, there are lots of inclusion-exclusion criteria, but the key exclusion criteria, I think, were 2, H. pylori infection and Barrett's esophagus. And although we didn't actually do something to ensure this, our goal was to have about 30% of the patients have more severe LA grade CD esophagitis. And we ended up enrolling patients at 77 sites in the US and 34 in Europe. Well, importantly, you always want to talk about how you did the randomization, blinding, et cetera. So randomization was performed with concealed allocation using an interactive response technology that accessed a central randomization sequence. And there was one stratification factor, LA grade, A and B versus C and D. The study was blinded, and that was accomplished by having study medications with an identical appearance, and this was accomplished with encapsulation around the medication. And all study medications were taken 30 minutes before the morning meal, which is, as you know, what's typically recommended, at least for proton pump inhibitors, but not necessarily for the PCABs. Now, this shows the study flow. As I mentioned, people were randomly assigned, and they were assigned to either vonoprazan 20 milligrams or lansoprazole 30 milligrams daily. At week 2, they had an endoscopy, and if they were healed, they could move on to the second study, if you will, the maintenance phase study. If they were not healed, they continued therapy and had a repeat endoscopy at week 8. If they were healed, they also could be entered into the maintenance phase. And in the maintenance phase, patients were re-randomized in a 1:1:1 ratio to vonoprazan either 20 milligrams or 10 milligrams, or the lansoprazole at 15 milligrams, which is the approved dose for maintenance of healing. And then they were followed, and at week 24, they had a repeat endoscopy to assess their maintenance of healing. Now, what were the primary endpoints in our study? Well, in the healing phase, it was the proportion of people who had healed by week 8. And in the maintenance phase, it was the proportion who maintained healing after a 24-week period. Now, let me go into the statistical analysis in a little bit of detail. As I mentioned, there were 2 phases or portions of the study. In the healing phase, the primary analysis was a comparison of healing, but it was not a superiority study. It was a non-inferiority comparison as the primary analysis. And I'll go into this a little more, but the margin was 10%. The sample size chosen was 1,000 based on that. And if non-inferiority was shown, we did predefine exploratory analysis for superiority. Now, the primary analysis in the maintenance phase was, again, comparison for maintenance of healing, again, a non-inferiority study with a margin predefined of 10%. And the sample size there was about 800, as you can see. And again, if non-inferiority was shown, a secondary analysis was predefined for superiority. Now, we can talk about it more later, but you can't just keep, doing tons and tons of comparisons and just say, oh, P equals 0.05 is significant for all of them. It's kind of a little pet peeve of mine that many studies do that. So actually, what we did is a kind of a typical hierarchical fixed sequence testing process. And in this case, what you do is you define the secondary outcomes or endpoints in a fixed sequence, and you basically do a comparison in that sequence. And you do each comparison at the P equals 0.05 level. And the minute one is no longer P less than 0.05, you stop and you don't do no further hypothesis testing. And I'll take you through that when we go through the results. Now, I think that, journal clubs, at least when I like to do them at our places, shouldn't just be kind of a recitation of the study, but it's nice to kind of talk about aspects of study design and methodology. So I thought I'd digress just for a moment to talk about, what we do when we're making assumptions for non-inferiority study. And one of the big things is, how do you determine the non-inferiority margin for a study? We're kind of used to the superiority studies, but not as much the non-inferiority margins, perhaps. And I like to point out that when you're determining a non-inferiority margin, you kind of have two different aspects you consider, the clinical and the statistical. First, the clinical. What's the maximal difference you would consider as clinically non-inferior? Or perhaps said a better way is, what is not unacceptably worse than the active control? So that's kind of the clinical way to think, of non-inferiority. But you also need to consider the statistical aspects of the margin, because you need to maintain the benefit above placebo. And what do I mean by that? Let me just give you a little example I'd like to talk about. So let's say the active control in your non-inferiority study is, in this case, let's say lansoprazole, the PPI, is 20% more efficacious than placebo based on older randomized trials. Now, if I chose a non-inferiority margin of 20%, I would be saying that the new therapy could be considered non-inferior, but also no better than placebo. Well, that wouldn't make any sense, right? So it's really important to make sure that the margin has to retain, it's usually recommended, over 50% of the active control treatment effect. So if, for instance, the active control is 20% better than placebo, you would want to make sure the non-inferiority margin is no greater than 10%. And that's really important to check when you're looking at people who are developing non-inferiority studies. So remember, the other thing is the margin in the non-inferiority study is not based on the observed difference, it's based on the bound of the confidence interval of the difference. So let's just take a couple of examples in which we've defined the non-inferiority margin for a new therapy versus an active control of 10%. And two different examples, in both cases, the observed difference is 10%. But in the first case, the lower bound of the confidence interval is minus 12%. We would not say that's non-inferior. We would not conclude non-inferiority. Let's say we have the same observed difference of 10%, but in this case, the lower bound of the confidence interval is minus 2%. That's a lot less than 10%. So in that case, we would actually conclude that non-inferiority was documented. So let's just go back to our study and just show you an example of how we did this in the non-inferiority margin. So we, let's say, chose this non-inferiority margin of 10%, and that means we require the lower bound of the confidence interval of vonoprazan versus lansoprazole to be above minus 10%. And what was the statistical basis? Well, we looked at old randomized trials of lansoprazole, 30 milligrams versus placebo. And in the two studies, the lower bound of the confidence intervals were 26% and 48%. So a 10% margin retains at least 62% of the treatment effect of lansoprazole over placebo. How do we do that? Well, not to get too far into the weeds, but 10 over 26 minus 10 is 62%, or 0.62. So again, I like to kind of discuss stuff like this because I'm really into clinical research as we go through studies such as this. So let's get back to our methods. What were the populations we chose when we were looking at our efficacy analysis? As you know, typically people use intent to treat, or ITT, for superiority. But what did we do for our primary analyses for non-inferiority? Well, one, we use kind of something that's typically done in studies, especially those for drug registration, modified intent to treat, which just means they had to receive a dose of the study medication and really have the disease that was intended. That is either erosive esophagitis, or the maintenance phase, they had to have baseline healing erosive esophagitis. We also predefined a per protocol analysis. And in that case, they had to have received and been compliant with the assigned study medicine. They couldn't have other anti-acid drugs. They had to actually get their endoscopy when they were supposed to get their endoscopy, and they couldn't have other major protocol deviations. either. So let's just talk about that. Why do you choose intent to treat or per protocol, and what's the right way to do it in a non-inferiority versus superiority study? Well, one thing I like to think about when I'm designing a study and the analysis is you always want to choose the most conservative analysis. You don't want to choose something that's more likely to be positive or favor the intervention that you're studying. You actually want, if anything, to choose one that's more conservative, that is less likely to favor the intervention, because then if you actually show that there is superiority or non-inferiority, it's actually more rigorous, if you will. And as you know, we're taught that per protocol is not really real world. It assesses the intervention in optimal circumstances because people are excluded if they don't adhere, if they drop out, if they have protocol violations. And because of the fact that this may therefore bias in favor of a treatment difference, it provides the best possible results of the new therapy. We don't usually make the per protocol the primary analysis or primary population to analyze in a superiority study. We usually use the ITT because that avoids a bias to the treatment difference. So it's actually the more conservative approach in a superiority trial. But is that true in a non-inferiority study? Well, not necessarily. The ITT analysis actually can bias to no treatment difference, which would be biasing to non-inferiority. And let's just take the most ridiculous example. Let's say you have this randomized trial that's non-inferiority, and no subject in either arm receives the assigned treatment. While the intent to treat analysis is going to actually show no difference between the arms, it really wouldn't, be a fair, assessment of non-inferiority. So most people, or pretty much everybody, agrees that a per protocol analysis should be included in a non-inferiority trial. There is some debate. In the older days, people said that should be the primary. Now people just make sure that it should at least be included. And ideally, there shouldn't be that much difference between the ITT and per protocol. But some people would suggest per protocol actually may be the more conservative analysis. So let's get back to our study now. I don't want to digress too much. And these are the selected baseline characteristics, usually table 1 that everybody looks at. So I won't spend a lot of time on this, but just our population in general, we're about 50 years of age. Women and men were fairly close. About 60% were from the US and about 40% from Europe. About 90% were white patients. Black patients constituted about 5 or 6%. And Latin ethnicity was about, as you can see, about 11 or 12%. BMI was somewhat higher, as you might expect in the US and European population, of about 31. Almost nobody was a CYP2C19 more metabolizer. We'll talk more about that, but it's much higher in Asia. And again, we were able to find that about 2/3 had LA grade AB and about 1/3 had LA grade CD. So we had a decent number of LA grade CDs. And let's start going through the results. This is the primary analysis, the primary endpoint for the healing phase. And we can see healing by 8 weeks in the overall group, just over 500 patients in each arm. The difference, as you can see, was about 8%. And you see both sides of the confidence interval were above 0. And so this did achieve non-inferiority, and the exploratory analysis, as you can see by the confidence interval, also indicated superiority of the PCAB. Now, the per protocol analysis, again, like I said, this is something that's important in a non-inferiority analysis. And you see the results are almost the same, which is reassuring. And again, does show consistency in terms of non-inferiority. Now, this gets confusing, but let's go through the fixed sequence of secondary analyses. And again, we defined these and they had to be done in an order. I won't bore with you too much, but the next outcome was heartburn-free days, the mean percentage. And you can see that there was about it was 3% higher, the confidence interval crossed 0, but this was a non-inferiority comparison, and it did meet non-inferiority. The margin was, quite large, 15%. The next thing we looked at is healing early on at week 2 in the more severe grades C and D. And here we see about an 18% difference, and you see the confidence intervals again were both above 0. Next was sustained heartburn resolution by day 3, meaning for the next week they had no more heartburn starting at day 3. Here the difference was only 2%, and this was a superiority. So as you can see by the confidence intervals, it did not achieve superiority. So at this point, all hypothesis testing stops for the healing phase of the study. I will just show you the other 2 secondary endpoints that were predefined just for descriptive purposes, but this is not hypothesis testing. Again, we see that at 8 weeks, grade CD, still had a difference in healing of about 20%, and healing at week 2 in the overall group also was about 6% difference. Now let's move on and look at the maintenance phase. And this was a little more complicated because it was 20 milligrams versus the PPI, and then it was 10 milligrams versus the PPI in fixed sequence. But as you can see here, there was about a 9% difference and a 7% difference, and this met the criteria for non-inferiority, and it also met the secondary analysis criteria for superiority, as you can see. In the per protocol, again, we did this for the non-inferiority comparison. Again, we see similar, if not greater differences. So this clearly also met the non-inferiority criteria for both the 20 and 10 milligram doses of the PCAB vonoprazan. And just quickly to go through the secondary analyses, here we see that healing maintained an LA grade CD. This was somewhat higher as you'd expect, 16% and 13%. And in both cases, there was suggestion of superiority. And finally, 24-hour heartburn-free days. Again, this was a non-inferiority initially. And you can see here that it did establish non-inferiority. It was just a couple % difference here in the mean heartburn-free days between the two medications. Now, very quickly, we did a post hoc analysis just to look at LA grade AB. So I showed you CD, but let's just look at LA AB. In all cases, we see a small numerical difference with vonoprazan being, anywhere from 2 to 5% higher than lansoprazole. But the confidence interval will show you that the bounds of the confidence interval cross 0. So certainly we couldn't say that it established superiority by any means, even though, of course, this is a post hoc analysis, not predefined, so we shouldn't even really be talking about superiority. And then let's talk about safety and tolerability. We all know about the issues that are discussed all the time with PPIs, and Paul obviously has great expertise in that as well. And so certainly the issue comes up, what are the effects of another agent that also inhibits acid and may inhibits acid to a greater degree. So just to go through these, again, just looking at the adverse events, the serious adverse events leading to discontinuation. COVID-19 was the most common in the maintenance phase. We also looked at special interest things such as C. difficile and bone fracture and liver test abnormalities, because some of the original different PCABs had liver test abnormalities. And honestly, I don't know that anything jumps out. There certainly could be a slightly higher rate of SAEs in COVID. But I think the one thing that's very clear is that the serum gastrin levels are clearly higher with vonoprazan than the lansoprazole. So the PCAB, as you might expect, with greater acid inhibition comes greater elevation in serum gastrin. Now, 4 weeks after end of therapy, it did come down in all groups. Still about, at 4 weeks, about double what it was at baseline. And something else we did is we actually took baseline biopsies from the Anterman body and then baseline biopsies at the end of the maintenance phase. And we looked at a variety of things. I'm showing a variety of things here: intestinal metaplasia, issues related to neuroendocrine cell proliferation, and then ECL cell hyperplasia, which clearly has been associated with PPI use as well. And what we can see is that it was really very minimal in this study, although again, the study may not have been long enough to really assess histologic changes. The only thing where there could be any possibility of a slight difference, the ECL hyperplasia perhaps was slightly higher in the higher dose of vonoprazan than the lansoprazole. But again, it's, you don't want to overstate anything here. So basically, taking all that together, we can say that the primary hypothesis that vonoprazan was non-inferior to lansoprazole in healing and maintenance of healing was confirmed. And in addition, vonoprazan did achieve higher rates of healing and maintenance of healing. Now, of course, the differences were greater in LA grade CD than LA grade AB. And if we really try to be careful with our wording about what we showed, the pre-specified analysis did show that vonoprazan was superior in LA grade CD. That occurred as early as 2 weeks and then was kind of maintained throughout the study. And post hoc analysis did not establish vonoprazan superior in LA grade AB. So our observed 8.3% difference in healing was greater than those Asian studies that I showed you earlier, despite all studies having comparable LA grade CD. What are some potential explanations for that? Well, as we mentioned, in a Western population, there's much lower proportion who have CYP2C19 poor metabolizers. And of course, this is one of the important ways that PPIs are metabolized. So it can increase the efficacy of the PPI. And also H. pylori infection was excluded from our study, but not Asian studies, and PPIs can show greater efficacy with HP infection. The other thing I think is important, this study, and I think old API studies show us the same thing, just achieving greater and greater intergastric acid inhibition does not necessarily fully translate into better heartburn control. And I think that's an important, point that we all should know. The strengths I would suggest of our study, it was a very large multi-center double-blind randomized controlled trial. And as I mentioned, having central adjudication of the erosive esophagitis for all eligibility and outcomes, I think was an important strength. Limitations, I think, are especially generalizability. Our study population was primarily European, all white European population and the US population. We did not have H. pylori positive patients. And again, I think there are differences between erosive and non-erosive patients, especially with GERD symptoms. So we can't necessarily just generalize to those who have GERD symptoms without erosive esophagitis. So I would say in conclusion that vonoprazan was non-inferior and superior to the PPI lansoprazole in healing and maintenance in HP negative patients from the US and Europe, but the superiority is predominantly in the more severe esophagitis. Well, again, I really appreciate the opportunity to participate in this. It was really kind of you to invite me. I am honored by being the inaugural Journal Club member, and I'll look forward to hopefully a vigorous discussion, and I'll stop sharing.
Thank you for that wonderful presentation, Dr. Lane. I must say it really is a treat to get your own insights and perspective on this paper, especially as one of the main authors. As Dr. Moietti mentioned earlier, my name is Dennis Wang. I'm one of the co-chief residents at the Gastroenterology residency program at McMaster University. I do have the pleasure of sharing that role with my co-chief residents, Julie Tan and Cara Prey. We are joined with all of our GI fellows here, as well as our program director, Eric Greenwald. Now, we all read your paper with great enthusiasm, and we've come up with a few questions about the paper. Our first question comes from one of our fellows, Lauren, if you please.
Good morning. Thanks for the start, Dr. Lin. So there are already systematic reviews that show that PCABs are more effective at healing esophagitis than PPIs. So my question was, why was there a need for this particular trial?
Well, first, I guess I'm not sure I would absolutely agree with that statement. I mean, there are a number of meta-analyses, and I guess let's split meta-analyses. First, more of them are probably so-called network meta-analyses, perhaps. And one of the reasons I'm not sure I would accept that as especially strong evidence, especially because some of these will have like dozens of PPI studies and then a very small number of PCAB studies, and try to make judgments about PCABs versus vonoprazan. But in any event, even the most recent network meta-analysis I know of, published just a couple of months ago online in Medicine, didn't show vonoprazan superior to all PPIs. And so I think there's mixed ones. I personally, in this case, would prefer looking at a direct comparison meta-analysis, where they looked at just studies where they actually compare vonoprazan or other PCABs to PPIs. And the one that I know, the latest one I know of that, published late in 2020, didn't show benefit of PCABs over PPIs for healing at week 8, whether they looked just at vonoprazan or they were looking at all PCABs. So remember, I mentioned that there were only 3 studies I know of that were looked at healing, and they were all from Asia, and they were only 1 to 3.5% differences. So, I don't think that we knew that for sure, which was surprising based on the Asian, studies. And in addition, we did, do make the point that there are marked differences between populations in Asia and the US and Europe. So that's another reason that even if a study does show benefit in Asia, we might need to do it if it's an acid inhibitory study in the US or European population. And I guess one other thing I'll just mention is, although I do know we talk about the hierarchy of, of different type studies, starting with case controls and case series on the bottom and case reports on the bottom, and going up to randomized trials, and then actually meta-analysis, systematic reviews and meta-analysis are at the top. But I'm not sure I always agree with that. I guess I would say that a well-done, properly sized, double-blind, randomized controlled trial can be viewed as stronger evidence, let's say, than a meta-analysis of a limited number of smaller randomized trials. So again, I don't want to say that a meta-analysis always is better. And just as an interesting point, our study had, over 1,000 patients. That was almost the same number as all three of the previous randomized controlled trials combined. So for all those reasons, I think, and I know I went on and on with that, I do think that there probably was reason and justification for doing this. And finally, a practical reason for a study to be registered. Again, it can be from other countries as well, but this was also going to be used for registration of this medication for erosive esophagitis.
Thank you, Lauren, for the question, and thank you, Dr. Lane, for that answer.
Great name, Lauren. Thank you. Yeah.
That's great. Our next question comes from one of our other fellows, Kieran. Kieran, what is your question?
All right. Yeah, thanks again, Dr. Lane. Really good talk. So I just had a question with regards to the maintenance data and kind of between group differences of the vonoprazan dosing. So the question is really, do we think that the 20 milligram dosing is justifiable based on a near doubling in sort of severe adverse events, although they weren't overall that common, and also that there was about a, within or between group less than 2% difference in outcomes between the 20 milligrams and the 10 milligram dosing? Just what your thoughts are in general with that.
Yeah, absolutely. And I think as I hear that, I think there's maybe two questions in that. The first would be, was it justifiable to have studied this dose? And then the second would be, is it justifiable to use this dose in practice, when this agent presumably becomes available? It is already available for years in Asia. So I think it was justifiable to study the dose in the study. And we made that decision because the Japanese study had shown that 20 milligrams had numerically greater maintenance of healing than 10, at least for the more severe esophagitis patients, the LA grade CD. It was about 8% better, something like that. So I do think it was justifiable because it is important to kind of, do that dose ranging. But I do agree with you absolutely based on our results. I think most of us would conclude what you have, that 10 milligram dose would be the one you would use. It has, as you said, almost the same efficacy at the lower dose. And again, as we'll talk about again and again, I'm sure you always want to use the lowest effective dose. And you certainly, if you aren't getting much more efficacy, and there's always a chance of greater side effects, I absolutely agree. It would make sense in general to choose that lower dose.
Thanks.
Thanks, Kieran. Our next question comes from Kayla, or one of our fellows. Kayla, if you please.
Thanks for your talk, Dr. Lane. I was hoping to get your opinion on, given the fact that you found vonoprazan 10 milligrams to be non-inferior during the maintenance phase without really greater symptomatic relief, would you recommend using the vonoprazan 20 milligrams for the first 8 weeks of healing and then switching to 10 for maintenance?
I think that's very reasonable. Again, I do think when we do guidelines, actually Paul and I have done a number of guidelines. You really want to make your recommendations based on the best data you have. And I think these data and others would suggest just what you said. We do see that 20 milligrams was good for maintenance. But as you mentioned, the 10 milligrams did seem to be pretty comparable. And again, for PPIs, for PCABs, probably anything, you always want to reduce the dose to reduce any chance of any side effects. And as long as you're maintaining efficacy. And again, for 8 weeks, 20 milligrams, not particularly a problem, but it makes sense. And again, we do this with PPIs as well. You lower the dose when you're going to put those patients on it long term. So I absolutely agree with your suggestion and your conclusion.
All right. Thank you, Kayla. Our next question comes from Julie, one of our co-chief presidents. Julie, what is your question?
Hi, Dr. Lane. Thank you for your talk. My question is about why, in particular, the comparator was chosen to be lansoprazole 30 milligrams daily. Do you think a similar effect would have been seen with a single enantiomer drugs such as esomeprazole or dexlansoprazole? And what do you think the results would be, let's say, compared to a twice daily PPI dosing as opposed to once daily?
Sure. Those are all good questions, and it may take me a while to answer all of them, but let me just kind of go through them. First, lansoprazole is among the most commonly used PPIs over the years, and 30 milligrams is the standard dose. It's most often used. It is also, importantly, the FDA-approved dose for healing, both in the US and in Europe. And although there may be minor differences among PPIs, I'm more of a lumper than a splitter. I generally suggest they're relatively comparable in efficacy, especially when you consider dosing. For instance, I'll talk about a couple of examples. I don't have slides for them, but you asked first about lansoprazole 30 versus esomeprazole and dexlansoprazole. And there are large studies that kind of address your question. And actually, the first it kind of reminded me of a study from almost 20 years ago now. There was this massive study done on over 5,000 patients. It was sponsored by the makers of esomeprazole. And to me, this is an example of a really well-conducted study that still you might raise questions about, related to the industry sponsorship, related not to the way the study was done, but kind of almost how it was designed. So this is an interesting study because they randomly assigned over 5,200 patients to either esomeprazole 40 or lansoprazole 30. And you might ask, well, why do they need such a large study? Well, they powered the study to detect a 3% difference in efficacy in healing, between the two groups. So I think most people who are clinicians are going to say 3% difference. We're not going to accept that as clinically meaningful, especially if one drug is, let's say, more expensive than the other. So what they find? Well, when they entered 5,200 or however many patients, they found a 3.8% greater healing with esomeprazole than lansoprazole. So I actually always like to point this out as an example of a well-done study, well-conducted, and they conclude, that one drug is better than another. But again, I don't think most of us would actually suggest that. So again, I use that to say that there are differences among PPIs, don't get me wrong, and also relate to the doses that you use, but I don't think that they are major. So I don't know that I differentiate to a tremendous amount. And actually, there are other studies of esomeprazole, and they don't show dramatic. Some show more than others healing. And actually, what about dexlansoprazole that you mentioned? Interestingly, the two studies that were used to register dexlansoprazole 60 milligrams, which is the higher dose that's available in the United States at least, compared it to lansoprazole 30 milligrams. So we have a direct answer to your question. So dexlansoprazole 60, right? Not 30, but 60 compared to lansoprazole 30. And these were 8-week healing studies. And what did they find? They did not find that they achieved statistical significance between their new dexlansoprazole 60 rather, and lansoprazole 30. So again, fascinating that these studies were done and don't show these differences, that yet we kind of have this idea that we should, even though there may be differences in pH studies and things like that, that doesn't always translate into, into differences in healing, which I think is important to keep in mind. And so there were small differences, but they were just a few percent again. And your question about twice daily PPIs is really important because all of us, me included, we always go from once daily to twice daily PPI. And there's certainly good acid, pH studies that do support doing that. It's interesting though, the actual clinical data, especially for things like healing, there's not really that much of it to really truly document a difference. To my knowledge, for instance, a recent systematic review, or not that recent systematic review, only identified a couple studies where they actually compared twice daily to once daily PPI, and that was 20 versus 10 of rabeprazole. And one study showed no benefit, the other study showed a significant benefit. So I do agree that twice daily probably would, theoretically improve things. It certainly does improve acid, but I think we don't have enough information. But I certainly take your point, and I do agree that that's the way I treat patients in practice. I go from once daily to twice daily, and with GERD, there are old data suggesting even 3 times daily is beneficial. And certainly in a GI practice, I sometimes go to that and sometimes find benefit with that.
Hey, thank you, Julie. Our next question comes from Cara, one of our other co-chief residents. What is your question, Cara?
Hi, Dr. Lane. Thank you again for your presentation and your time. So you did partially address this during your presentation in terms of the post hoc analysis, where you talked about, the efficacy of vonoprazan in treating different grades of esophagitis. So essentially, so you showed that the healing that was demonstrated was greater in more severe esophagitis. So is perhaps a take home from your work to inform our clinical practice that potentially there could be a hierarchy of choice in terms of acid suppressing medication. So what I mean in, say, LA A or B, using, in quotes, a lower potency medication, and then C or D, a higher potency medication such as vonoprazan.
Right. Well, of course, it's always hard to predict absolutely how people will use this. It relates to lots of things, not just efficacy, but cost and, at least in the United States, insurance coverage and all sorts of other things. But I do think that your point is probably correct. Again, if one hasn't shown that it is superior in the standard LA grade AB, I do believe that most physicians, including myself, would go for the less expensive and, drug that is shown to be, relatively similar in efficacy, certainly initially. And I also agree that, again, it will be hard to say exactly what the, the niche and the indication will be, but certainly it's the LA grade CD where this agent shows, a pretty marked difference. And so I would agree that that would be the situation in which you would be most likely to use this agent.
All right, thanks, Cara. I think we have time for one more question. Our next question comes from Ala. Ala, please.
Thank you, Dr. Lang. My question is, where do you see the place for vonoprazan in a clinical practice if it gets approval for gastroesophageal reflux disease?
Sure. I mean, again, as I said, it's hard to predict for sure, and a lot of this relates to lots of other things as well. But I'd say a couple things. One, we didn't talk about it here, but H. pylori treatment, there are a number of studies from Asia, and one recent published in Gastroenterology that do suggest that vonoprazan instead of the PPI does increase the rate of eradication, probably, no matter which of the different regimens you use, certainly for dual and triple therapy. And so I think, and especially because those regimens are only 2 weeks in duration, you don't have the same worry about increased cost, about, duration of acid suppression. So I would think H. pylori, many people feel is going to be a place. We just talked about the fact that I think in GERD, it's really going to, would be, you would not choose it in everybody, but you would choose it in those who have the most severe erosive esophagitis, as we just talked about. Another interesting idea I'll just throw out here, I know others have talked about, is the idea of on-demand therapy. As you know, many patients, they take their PPIs on demand. They develop symptoms, they're more bothersome, and then they decide I'll take a medicine for a day or a few days, and then, I'll stop. And there are a number of studies that have looked at this with PPIs, and the only issue with PPIs is they may take a few days to reach peak acid inhibition. So the idea that if a drug could have a more rapid acid inhibition, could it be used, on demand? It's intriguing. And Ronnie Fast at the last ACG meeting presented some fairly good results for this idea, getting rapid relief, So I think, again, I don't want to, I'm not endorsing anything, but I'm just saying this is an intriguing place for me to use it. You would just be using it, short term because of its, pharmacodynamic, basically characteristics. And it's something that I think will be interesting to look at further down the line.
All right, thank you, Ala. So I think now we're at the 45-minute mark. Well, first off, I'd really like to express my thanks, Dr. Lane. Really appreciate your time in presenting this new paper and sharing your thoughts about the role that vonoprazan might play in erosive esophagitis. I really appreciate your time. I'd also like to thank McMaster University for helping us to organize this, as well as Dr. Moyetti and the team at the Journal of Gastroenterology for setting up this initiative. So it's a really exciting new venture that we are going to.
Well, thank you very much again for including me in this.
My pleasure.
Yeah. So thank you very much, everyone. Great session. You learned that Dr. Lane has encyclopedic knowledge and a great paper, so we're proud to have in gastroenterology. So thank you very much, Professor Lane, and all of you here. Thank you.